So dynamic auscultation part. So on Valsalva or standing suddenly, that will lead to decreased venous return or decreased preload. So that will lead to decrease in cavity size. When the cavity size is decreased, it will lead to more alveolar obstruction or systolic anterior motion of the leaflet. It will lead to intensity murmur. When there is less blood, there will be less stretching of the ventricle. So this anterior material leaflet and this septum, they are closer to each other. When they are close, they will cause obstruction of the left ventricular outflow tract. That will lead to, when the blood passes through the narrow channel, there will be turbulent flow, so the murmur will be loud. So when there is less blood inside the ventricle, the anterior mitral leaflet and the septum are close to each other. They will create a narrow passage for blood, and when this blood passes through this narrow passage, there will be a loud murmur. So in squatting or passive leg rest test, there will be increased preload because there will be increased venous return. So when there will be increased preload or increased venous return, increased blood volume inside the left ventricle, then now the left ventricle will stretch. When this left ventricle will stretch, now the septum and anterior mitral leaflet, they will move far away from each other. When the septum and anterior mitral leaflet, they move far away from each other, then there will be the left ventricular outflow tract obstruction will be relieved. Now blood can easily move across the aortic valve. So there will be less alveolar obstruction. So in squatting or passive leg raise, there will be increase in preload. Increase in preload lead to increase in cavity size, which will lead to more stretching. That will lead to decrease in alveolar obstruction. So septum and anterior mitral leaflet are far apart due to stretching of the ventricle. So that will lead to decrease in intensity of murmur because this anterior mitral leaflet and septum are far apart. Blood can move easily. There is no narrow passage, so the murmur intensity will decrease. So remember, as a rule, when there is less blood volume, the anterior mitral leaflet and the septum are close to each other because of less ventricular stretching. That will lead to a obstruction of the left ventricular outflow tract, which will lead to loud murmur. When there is more ventricular filling, increase in cavity size, more stretching, these two things, AML and septum, are far apart from each other. That will create easy passage for blood, so the murmur intensity will decrease. So on hand grip or giving phenylephrine is a vasoconstrictor alpha agonist. So on doing hand grip or giving phenylephrine, there will be increase in systemic vascular resistance or increase in afterload. When there is increase in afterload, when there will be increase in afterload, blood is harder to eject because aortic pressure is high. Left ventricle is connected to aorta. When we are giving a vasoconstrictor like phenylephrine or doing hand grip exercises, that will lead to increase in systemic vascular resistance. So aortic pressure will rise. When aortic pressure is rising, now it will be difficult for the left ventricle to pump blood into the aorta. So blood is harder to eject because aortic pressure is high. So LV and systolic volume increases. So now LV will be not able to eject blood into the aorta easily. So there will be accumulation of more blood inside the left ventricle. That will lead to increase in blood volume inside the left ventricle. So LV cavity remains larger. That will lead to more stretching of the left ventricle cavity. That will lead to less systolic anterior motion of the leaflet, like this only. When there will be more blood, these two structures are far apart from each other, so less alveolar obstruction and the murmur intensity decreases. So on hand grip exercise or giving phenylephrine, the murmur intensity decreases in case of HOCM. We discussed the mechanism. So in HOCM, anything that makes the LV smaller makes the murmur louder. So in HOCM, anything that makes the LV smaller makes the murmur louder. This is also seen in case of mitral valve prolapse. Anything which makes the LV bigger or the left ventricular volume increases, that will lead to less intensity murmur. So on inhalation of amyl nitrate is a vasodilator. When we inhale amyl nitrate vasodilator, it will dilate the blood vessels across our body, that will lead to decrease in aortic pressure. When the aortic pressure is decreased, the afterload is decreased, so LV can eject blood easily into the aorta. That will lead to LV emptying. So LV empties more when there is decrease in afterload. That will lead to decreased blood volume inside the left ventricle, so smaller left ventricular cavity during systole. So smaller left ventricular cavity lead to when there is less blood inside the left ventricle, then the anterior mitral leaflet moves closer to the ventricular septum. That will lead to increase in LVOT obstruction. When there is increased LVOT obstruction, the HOCM murmur intensity increases. So on inhalation of amyl nitrite, HOCM murmur intensity increases. So on isoproterenol is a beta 1 plus beta 2 agonist, or digoxin, it is a inotrope, or exercise, or beta 1 stimulation. All these things lead to increase in heart rate. When the heart rate is increasing, the LV contractility will also increase. When the LV contractility will increase, the LV will contract vigorously and it will pump more blood into the aorta. That will lead to decrease in left ventricular size. So whatever decreases the left ventricular size increases the murmur intensity. So when there will be decrease in left ventricular size, the anterior mitral leaflet and the interventricular septum, they will move closer to each other. When they will move closer to each other due to systolic motion of anterior leaflet, there will be LV outflow tract obstruction. So murmur intensity will increase. So on giving inotrope, isoproterenol, or digoxin, it will lead to LVOT obstruction more. That's why digoxin is contraindicated here, and the murmur intensity increases. So what is preferred in case of HOCM? So we have to prefer less LVOT obstruction, because the problem is due to left ventricular outflow tract obstruction. So we have to make the LVOT obstruction less. So how we can make the LVOT obstruction less? By increasing the preload. When there is high preload, there will be more blood inside the left ventricle. That will lead to ventricular stretching. That will make these two structures, septum and the anterior mitral leaflet, far away from each other. That will lead to decrease in obstruction. When there is high afterload, the left ventricle can't pump much blood into the aorta, so more blood will remain inside the left ventricle. That will lead to ventricular dilatation or ventricular stretching. That will relieve the LVOT obstruction. Or low inotropy, high preload, high afterload, and low inotropy. So low inotropy means when there is less contraction, more blood will remain inside the left ventricle. That will stretch the left ventricular wall and it will decrease the LVOT obstruction. So high preload, high afterload, low inotropy. Another thing which associated with high afterload is that there is increased distance, so LV can't pump blood more into the left aorta. More blood will remain inside the LV. That will lead to dilatation of LV and stretching of LV. That will all these three conditions leading to more blood inside the left ventricle, which is leading to less obstruction in LV outflow tract, and it is preferred also, and there will be low intensity murmur in these cases also. So what is the treatment? Treatment is beta blocker or calcium channel blocker plus disopyramide. So drug of choice is beta blocker here, propranolol 2 mg per kg body weight. So maximum 480 mg we can give. So advantage is beta blocker decreases the heart rate. When the heart rate is decreased, the contractility is decreased, and there will be more blood remain inside the left ventricle. More volume means obstruction will be less, and that will decrease the LVOT gradient, increase the diastolic filling because the heart rate is reduced. There will be more diastolic filling, LV volume will increase, more stretching, all these things. So relief from angina by decreasing myocardial oxygen demand. So these are the uses of beta blocker. Why advantages of using beta blocker? It decreases the heart rate, decreases the LVOT gradient, increases the diastolic filling, relieves from angina by decreasing the myocardial oxygen demand. So when beta blocker is contraindicated, then we can use non-dihydropyridine calcium channel blocker like verapamil and diltiazem. Then these non-dihydropyridines have selective action on heart. Dihydropyridines are vasodilators, nifedipine, amlodipine, all this. And but verapamil and diltiazem, they are non-dihydropyridine. They act mostly on heart. They decrease the heart rate. Same as beta blocker. All these things will be there also. So disopyramide is a class 1A antiarrhythmic drugs and a negative inotrope opposite to digoxin. So it will decrease LV contractility. So there will be less left ventricular emptying, more blood will remain inside the LV, larger LV cavity, more stretching, less systolic motion of anterior leaflet, less LVOT, and it will help us to treat the patient. So what is the side effect of disopyramide? Disopyramide being a class 1 antibiotic, it causes QT prolongation. It has some anticholinergic side effect also, and it decreases the ejection fraction. So what is implantable cardiovascular defibrillator? So in ICD indications are history of cardiac arrest, family history of SCD, sustained ventricular tachycardia, abnormal Holter staging, and when the LVH is more than 30 mm, or there will be unexplained syncope. These are the indication of implantable cardiovascular defibrillator. So surgical management is indicated in refractory hypertrophic cardiomyopathy. The gradient is more than 50 mm of Hg despite of medical therapy. So methods are septal myomectomy greater than alcohol septal ablation. So septal myomectomy preferred in case of HOCM. So this is a pathology question. So in case of HOCM, mutation of beta myosin heavy chain seen in young athletes. Most common cause of death is arrhythmias in young athlete. So this is the histology, helter-skelter appearance, myofibrillary disarray. So this is the banana-shaped cavity due to asymmetrical hypertrophy of interventricular septum. This is the anterior mitral leaflet. They are the one which causes the obstruction to the left ventricular outflow tract. So now discuss about the various maneuvers or dynamic auscultation. So maneuver is inspiration. On inspiration, there will be increase venous return to right ventricle. There will be increase in intensity of right side murmur like TR and PR. So increase in TR murmur with inspiration is called Carvalho sign. On expiration, more blood to the left side of heart. So left side murmur intensity will increase on expiration. MSMR, ASAR intensity will increase on expiration. So on standing, there will be decrease in preload because venous pulling in the leg. So most murmur will decrease intensity. When there will be decreased preload, then there will be more blood flowing across the valve. That will lead to decrease in intensity of murmur like MSMR, ASAR. All these murmur intensity will decrease on standing. But HOCM and MVP, their intensity will increase. MVP the duration will increase. HOCM the intensity will increase on standing because of decreased preload. The cavity size is reduced. We have discussed the mechanism earlier. In case of HOCM, there is smaller LV cavity, so septum and anterior mitral leaflet approximate more, obstruction worsens, and the murmur is loud. So in case of mitral valve prolapse, clicks occurs earlier, or the non-ejection click moves closer to S1 due to small left ventricular volume, so the murmur duration is prolonged on standing due to decreased preload. So on squatting, the preload is increased or the afterload is increased due to systemic vascular resistance increasing. So mostly the preload is increasing, most murmur increasing intensity. When the preload is increasing, more blood flow across the valve will occur. That will lead to increased intensity of most murmur like MSMR, ASR murmur intensity will increase on squatting. But HOCM and MVP murmur intensity will decrease on squatting because increasing preload increases the left ventricular volume. When the left ventricular cavity size is increased, mitral valve prolapse and HOCM murmur intensity decrease. We have discussed the mechanism. So on passive leg raise also, there will be increase in preload, the same result as squatting. So squatting has more stronger hemodynamic effect than passive leg raise. So HOCM, when there will be increase in preload, there will be large left ventricular cavity that will lead to reduced obstruction and murmur intensity will decrease. On mitral valve prolapse, larger left ventricle delays the prolapse. The non-ejection click moves far away from the S1, clicks becomes later, murmur duration decreases or it becomes softer. So on squatting or passive leg raise test, there is increase in preload which moves the mid systolic click or non-ejection click away from the S1. So on valsalva phase 2, increased training, decrease venous return, decrease preload. Decrease preload means most murmur will decrease in intensity except HOCM and MVP. So MVP earlier creek, increase duration of murmur, HOCM increase intensity of murmur due to less blood inside the left ventricle. So on hand grip, there is increase in systemic vascular resistance, increase in afterload. So when there will be increase in afterload, all the recurrent murmurs like MR murmur and AR murmur, they will increase intensity. When there is increase in afterload, regurgitant murmur will increase in intensity. Because the afterload is increasing, now there will be less forward flow, more backward flow. So the recurrent murmurs in case of AR and MR, there will be more blood flowing across the valve backwards. So the murmur intensity will increase when there is, in case of mitral regurgitation and aortic regurgitation and VSD, if the systemic vascular resistance is increasing or the afterload increasing. So in case of hand grip, increase systemic vascular resistance, increase afterload, all the regurgitant murmur will have increased intensity. So more regurgitation backward into the low pressure chambers. In MR, the murmur intensity will increase. AR, the murmur intensity will increase with hand grip, and in VSD also murmur intensity will increase with hand grip. In case of stenotic lesion, so in AS, due to high afterload, it reduces the flow across the systolic aortic valves. So when stenotic aortic valve, when there will be increased aortic pressure due to high afterload or increased systemic vascular resistance due to hand grip, then there will be less flow across this stenos valve. So murmur intensity will decrease in case of aortic stenosis. But it is not true with mitral stenosis, because in mitral stenosis, when we are doing hand grip, there will be a sympathetic surge which will create tachycardia, and it will create more flow across the mitral valve, and the mitral valve intensity, murmur intensity will increase. We'll discuss that. So in HOCM, hand grip leads to increase in systemic vascular resistance or increase in afterload. So more left ventricular volume remains inside the, more blood remains in the left ventricle, because ventricle can't pump because the afterload is increased. When there will be more blood remaining inside the left ventricle, so the septum and anteromitral leaflet are less likely to approximate. So the dynamic LV outflow obstruction decreases, the murmur intensity will decrease. In case of mitral valve prolapse, prolapse is favored more when LV cavity is small. Here the LV cavity is large, so there will be less prolapse because there will be no kinking of the chordae tendineae. The chordae are tight, which pulls the prolapse, the mitral valves down. So there will be less prolapse. So there will be less murmur when there is increase in cavity size. So in hand grip, there will be increase in left ventricular volume or size during systole. So mitral prolapse, valve prolapse occurs later. So mid systolic click moves later or moves away from S1, so murmur becomes softer and its duration becomes shorter. So in case of MS with hand grip, due to increase in afterload, there will be increase in left ventricular systolic pressure. Another thing is there will be increase in sympathetic activity, that will lead to increase in heart rate, that will lead to increase in venous return and cardiac output. So there will be more blood flowing across the mitral valve, that will lead to increase in murmur intensity. So this is all about dynamic auscultation. So this is the most important slide. As you can see, when there is less blood remaining inside the, when there is less blood inside the left ventricle, there will be more kinking of the chordae tendineae. When there will be more kinking of the chordae tendineae, when this ventricle will contract, there will be more intensity or duration of the murmur will be prolonged. When there is more blood inside the left ventricle in case of mitral valve prolapse, there will be more stretching of the valve. Now the chordae become tight. When the chordae become tight, there will be less motion of the mitral leaflet, that will lead to decrease in intensity of murmur or decrease in duration of the murmur. In case of hypertrophic obstructive cardiomyopathy, when there is less blood inside the left ventricle, same thing, the anteromitral leaflet and septum are closer to each other, they will create more obstruction, murmur intensity will increase. When there will be more blood inside the left ventricle, it will stretch more, that will lead to move apart the ventricular septum and anteromitral leaflet, they move apart away from each other, that will create easy passage for blood, and there will be less obstruction, left ventricular outflow less obstruction, and the murmur intensity will decrease. So this is the basic thing in this whole lecture. So this is all about it.